Dr. Wozniowski, and I'm the honors coordinator for psychology. It's a pleasure to be here to chair the session and hear about the excellent research that folks are doing in this department and in other departments as well. We will have either 2 or 3 presenters. Hopefully presenter number 3 is on his way. I will introduce each of the speakers. They will give their talks and we'll have a couple of minutes for questions. So we will get started with our first presenter, Nicholas Novakovich. And Nicholas is a psychology major in his junior year at Greensboro College. And he's in the honors program there with a 4.0 GPA, all semesters on the Dean's List. And he's also been inducted into the Psychi International Honor Society in Psychology. Welcome, Nicholas, and you can take it away whenever you're ready.
All right, let me go ahead and share my screen here real fast. Oh, seem to be having issues this time around. I'll try one more time. Aha, there we go. All righty, so hi everyone. My name is Nick and I will be presenting on the potential for hearing aids to mitigate the psychosocial effects of hearing loss. This presentation is based on data that is being currently collected and processed, so much of the experimental data is hypothetical and subject to change during the course of my research. All right, so first, you might be wondering, what am I trying to determine through this study? I'm actually hoping to answer 2 main questions, and that is there a link between sensory neural hearing loss and psychological distress, low quality of life, and impaired social functioning? Second, do hearing aids actually mitigate these above factors? So to answer these questions, I developed a survey which would compare data between those who have worn hearing aids for over a month and those who have worn hearing aids for less than a month. Primarily, I will be focusing on adult and elderly patients receiving some form of audiological care. This is because there are very few patients in an audiological setting that have not received some form of exposure or interaction with hearing aids in the past. I will discuss these methods a bit in a later slide. So before I get into the intimate details of my research, you may be wondering, why am I researching such a specific topic? I would like to direct you to the following infographics. So if you look on the one on the left there, these graphs represent statistical findings on who is experiencing hearing loss and possible comorbid illnesses they may face. I want to focus on 2 specific data points in that left one, and that is dementia and depression. If you see there, the risk of dementia is almost 5 times higher in those with hearing loss as opposed to those without. I believe that this is likely a result of decreased mental health seen in that depression statistic, as well as social isolation brought on by hearing loss. Remember that number when we look at this next slide. So about 15 to 26% of the world's population actually experiences some form of hearing loss. In the US, that number is more around 14%. But researchers estimate that in the US, adults with hearing loss will actually jump from 44.1 million in 2020 to 73.5 by 2060. With this rapidly expanding population, the prevalence of dementia is also expected to rise nearly double every 20 years. So remember that 5 times more likely for people with hearing loss to develop dementia at some point in their life. I think most would agree that this should be really seen as a public health priority. And that in order to start correcting these negative trends, I think we need to look a bit more at the underlying information. And that's why I chose to talk about hearing loss today. So in order to briefly detract you from the depressing information that I just listed, I wanted to note just how far we've come in the last 100 years or so. So the first documented case of hearing loss was actually treated with a concoction of goat urine and insect larvae, which is pretty gross. So these people were often classified as mentally deficient and given reduced rights. For instance, in Roman times, people with hearing loss were actually banned from participating in religious ceremonies. Luckily though, in 1898, the first hearing aid device was created and oral rehabilitation programs have rapidly increased ever since, hopefully decreasing some of that stigma in earlier times. While this is great, I think we can do a little bit more. So, as I said earlier, I've developed a survey focusing on audiological patients suffering from sensory neural hearing loss. And sensory neural hearing loss, by the way, is distinct from conductive. It involves the inner ear functioning, so the nerves, the brain, the cochlea, that sort of thing. I chose that specifically because in an audiological office, you're way more likely to see someone with sensory neural hearing loss rather than someone that needs reconstruction. So, I have taken a randomly selected sample of 100 from the total population of patients at High Point Audiological, a local practice. These patients have a diverse range of socioeconomic backgrounds, age, and experience. While all subjects in the sample must have some form of sensory neural hearing loss, I've split them into two groups based on time wearing hearing aids, as I mentioned earlier. My final survey consists of several different questionnaires developed to specifically pinpoint psychological distress, quality of life, and social functioning. These questionnaires include the Kessler Psychological Distress Scale, the Hearing Handicap Inventory for Adults, Satisfaction with Life Scale, and Social Function Questionnaire. The information gleaned from these methods will be compared to an existing body of research in order to determine common traits amongst those with sensory neural hearing loss, as well as to determine a correlation between hearing aids and the reduction of the aforementioned traits. There have been several different studies isolating each of these, but I had not seen one that kind of highlighted each of these in tandem. So that's why I chose to create that survey. So far, I have obtained around 30 surveys, and those are split evenly between the two groups. From the time I've spent distributing these surveys, I've learned several things. So first, I learned that older patients absolutely despise surveys. I've given the survey to almost 100 people, and only 30 of them have given me back a survey that isn't completely blank. I've been yelled at, had the survey thrown back at me, and been given lectures on how dangerous surveys can actually be. Secondly, COVID-19 has severely affected the way that people answer questions related to social functioning. And I believe this is partly due to quarantine and also potentially long stays in the hospital with those infected with COVID-19. Thirdly, as with COVID, many of the older patients experience some form of cancer treatment or surgeries which negatively affect their social interaction and mental health. Fourthly, people fill in some really weird answers to yes or no questions. That's how I got the above information, and that one patient struggles to keep still, not because they have anxiety, but because they have restless knee syndrome. They wrote that in a yes or no question. So 5, age seems to be a confounding factor as well. Most of the patients in the aided group are significantly older than those of the non-aided group. Finally, of the 30 surveys that have been recorded, not blank, average scores tend to be lower in those non-aided patients, while average life satisfaction scores are higher in aided patients. Keep in mind, it's not a huge gap between those, but that's where noticeable trends I saw while looking at that information. There is almost no variation, however, in psychological distress scores between the two groups. So I believe that average life satisfaction score being higher in the aided group is could really be attributed to that age problem that I mentioned earlier. But the other scores seem to tell a different story. So my findings, based on the data acquired, show that scores do not vary drastically between the two groups. Based on this information, I believe that I will not be able to reject the null hypothesis in this scenario that hearing aids have no effect on psychosocial traits of hearing loss once research is finally completed. Data seems to show that hearing aids do not have as much of an effect on psychosocial traits of hearing loss as I had previously thought, at least given my sample. So therefore, I would propose an integrated care model where where patients can receive both hearing aids and some form of therapy for their hearing loss. Perhaps if we implement a process like this, we could see patients achieving a higher level of care, as well as hopefully a decline in those dementia rates that you saw earlier. And there are my sources. So thank you guys.
Thank you. That was wonderful. Really, really interesting stuff. Let's see if we have some questions. There's some time for questions, so please. Ask away. Do we have any takers for questions? Yeah, Jasmine, go ahead.
Yeah, I thought this was a really interesting talk, and I'm really excited to see what your results when you're done with the study look like. I was curious if you could tell us a little bit more about like what are the kinds of experiences or items that are on the social functioning questionnaire, just to get a little bit of a better sense of the kinds of social things you're looking at.
Right. So all of the questions actually come from existing, like I mentioned, existing questionnaires, but they deal a little bit with family scenarios. So are you easily aggravated when you're in a family situation? Those aren't specifically doctored toward hearing loss, but I think they fit pretty well. So that sort of thing, and that's where those non-aided seem to have a little bit of a tougher time in that social setting.
I have a question. I might have missed this. What was your age range within the study?
Right. So it's about, I did 50 to, I think, 85 would be the oldest there. So
Okay.
Trying not to limit myself too much, but I don't want to put teens and more elderly patients in the same group.
Sure. Do you think that for younger people that you might actually, if there were, say, a larger group of younger people, I wonder, people don't expect hearing loss when they're young. And I wonder if there'd be difficulty psychologically accepting that you might need a hearing aid. And I wonder within that group, whether you might actually see some interesting effects. What do you think about that?
Yeah, I actually, in the beginning, I researched more that teen and younger setting, and actually a lot of their social scores were more positive because they had time to acclimate to that. They had those that neuroplasticity to kind of learn how do I interact while, they were probably shunned in a school setting at home and that sort of thing. I think they got on a little bit better than the elderly population.
Right, which speaks to just your whole idea of a more integrative model. It's kind of like, what social support do you have? Are you needing an aid or not? Like, what are all the different pieces? That's a really interesting idea, is like integrating that. We have a comment from Jessica Sharp. She said, total response number currently, I assume she means participants. How do you think you can modify your methods to increase the response?
So I've gone about that several different ways. I've kind of put up some flyers that are kind of familiarizing the patients to that. If they see it a couple times, they go, okay, I can do that survey. It's trying to benefit us as opposed to some online survey. While we did begin, I am handing out those surveys. We also got the doctors involved because there's kind of that trust level between the doctor and new patients, and patients, especially with new patients. That's actually why I had to limit it a little bit to under a year, because the patients that had never been in the office before were very skeptical when they saw that survey. I had even one patient walk out, which is not like, I don't want to affect patients' perceptions of that practice. So those are some of the things that I've done and I'm going to continue to work on. Thanks. That was a great question.
Do we have other questions? Oh, here's one in the side in the chat. This may be off topic. Was there any consideration with the financial aspect of hearing aids?
Yes, that's actually one of the questions on one of the surveys. I think the social functioning is actually, are you having money issues? And that was one of the biggest or most answered question that had that higher score, that really brought up both the aided and non-aided, I think. So I think money is definitely an issue in receiving those hearing aids. Most of the patients that are coming into this office are either through insurance or their own means are receiving some form of hearing aids. But I didn't notice such a big gap between those that had received it and those that hadn't. So that's, working on that therapy aspect.
Mackenzie, I see your hand is up.
Yes. So I know that within like the deaf community, they view hearing aids and like cochlear implants in a certain light. Do you think that has any effect on like people getting hearing aids? Because I know people who have sensory neural hearing loss are also like a part of that deaf community.
Yeah, no, absolutely. Can you repeat that one more time? I didn't quite catch. I had a sound go off behind me. Sorry.
Yeah, no worries. I was just asking, I know that the deaf community views hearing aids and like cochlear implants and things a certain way, because I study speech and audiology
Right.
in undergrad. And I was just wondering if you think that that has any like implications or impacts on like people getting hearing aids, because I know people with sensory neural hearing loss are still sometimes like identify with that group.
Absolutely. So kind of what I was talking about with the younger age population, those that are more acclimated to that sort of surrounding, there isn't that stigma, then I believe it's totally acceptable that they don't pursue hearing aids, and they might even, be better off, I think, having that social support and that sort of thing in that community than maybe being able to hear or that sort of thing. So no, for sure, that's definitely a good question.
Yeah, thank you.
Excellent. If there's nothing else, we will move on to our next presenter. Wonderful. Thank you, Nicholas, once again.
Thank you.
Next, we have Stanasha Lowry. Stanasha's in my class currently, so I'm excited to see her here. She is an honors student. She's a senior, majoring in psychology and minoring in human development and family studies. She is a member of the Early Scientist Program and also a member of the Psi-Chi International Honor Society. And Stanasha, whenever you are ready, you can take it away.
Thank you. I'm going to start sharing my screen. Can all of you see this? Okay. So good afternoon. My name is Stanasha Lowry. This is my research proposal titled The Role of the Imposter Phenomenon on First-Generation College Students. And with the help of my faculty mentor, Dr. De Jesus, I will be conducting this study in the fall. So here's a brief overview of my presentation. I will first start off by introducing my topic, go to the statement of the problem, the objectives, my research question, methodology and sample questions, my hypotheses and predicted results, and then finish off with the limitations and significance of the study. So what is a first-generation college student? So this is an individual whose parents or guardian has not obtained a four-year college degree. And some of the challenges that they may face include paying for college, succeeding academically, joining clubs and sports, and finding a sense of belongingness. Many first-generation college students often express guilt with achieving further than their other family members, as well as shame and hopelessness. Additionally, these students express feeling isolated from their college peers. So according to a study in 2004 by Grant Ballone and colleagues on social support, participation, and college adjustment, they found supporting evidence that students who are isolated are less likely to adjust well to college, as well as master their college environment. So some of the effects of failing to master your environment include, can lead students to express feelings of inadequacy, less confidence, and fraudulent feelings, which leads me to the imposter phenomenon. So the imposter phenomenon is also referred to as the IP, and it is described as internal feelings of fraud, doubt in one's skills, and attributing one's success to luck. This concept was given the name in 1978 by Clance and Imes, and they aim to study the phenomenon in high-achieving women. Other research has expanded on Clance and Imes' initial study by looking at the relationship between the IP and high-achieving African-American and first-generation students, as well as racial minorities as a whole. The IP has also been studied in an academic setting. So multiple studies have established a relationship between the IP and perfectionism, the imposter phenomenon in mental health and university students, and imposters and predictors in minority college students. Previous research has yet to examine the facets of the IP as they integrate into an academic setting. So to be more specific, Recent studies have yet to unpack the IP by looking at self-identity and personality traits and their effect on first-generation college students. So before we dive into the details of the study, I want to express some statements of the problem relating to the imposter phenomenon. So the questions that led to creating this project include: what individuals does the imposter phenomenon affect? Can the IP affect performance? And how can college institutions better serve first-gen students? And the objectives of the study are as follows: study the IP in an academic setting, identify the relationship between the IP and first-gen students, and analyze the behaviors and performances of first-generation students compared to non-first-generation students. My research question states: how does the imposter phenomenon affect the overall college experience of first-generation students? To operationally define the IP, I will be measuring self-perception, self-efficacy, and the Big Five personality traits. Originally, it was just neuroticism. I wanted to get a better sense of personality in participants, so I'm going to include all 5 of the traits. So self-perception refers to a person's view of themselves. Self-efficacy refers to a personal belief in the ability to achieve a goal or purpose. And the Big Five personality traits are a continuum of 5 factors related to personality, and they include neuroticism, conscientiousness, agreeableness, openness, and extroversion. Now, to measure the overall college experience, I'll be focusing on academic achievement, specifically grade point average, as well as college life satisfaction and social connectedness. All right, so before we dive into my hypothesis, I wanted to go over my methods for the study. So the participants will be undergraduate psychology students, and they will be divided into 2 groups: a first-generation student or a non-first-generation student. So to complete the study, they will fill out a questionnaire through the SONA experiment scheduling system. And in regards to the analysis of the methods, this study will be a correlational mixed subject factorial design. Additionally, the independent variables will be operationally defined using the following scales: so the CIPS, the SSE, and the TIPI. So the student self-efficacy scale will measure both self-perception and self-efficacy. The dependent variables will be defined using grade point average, SWLS, and the social connectedness scale revised. The study will also include open-ended questions. So here are a few sample questions from the questionnaires that I will be using to measure the variables. So someone high in self-efficacy would agree with the statement: I am confident in my ability to learn, even if I am having a bad day. And someone who is high in extroversion would see themselves as extroverted and enthusiastic. As for the open-ended questions, these are just to gather details on specific experiences of the participants. So now that we have discussed my methods of the study, I will now talk about my hypotheses. So my first hypothesis states that first-generation college students are more likely to see the negative effects of imposterism compared to non-first-generation students. So in 2015, Petit and colleagues established a connection between generation status and the imposter phenomenon. As for the current study, we'll be looking to see how generation status relates to the imposter phenomenon. So if a student has a low GPA, would the results show that they are high in imposterism? Additionally, would generation status influence imposterism, and in exchange also affect grade point average? We'll be looking at this in all 3 dependent variables. And so my second hypothesis states So my second hypothesis is that a low grade point average will correlate with low self-perception. So in the graph of predicted results, we see that overall non-first generation college students score much higher than first generation students on both grade point average and self-perception. Additionally, we see that when GPA is low, so will self-perception be, and when GPA is high, self-perception will also be high. Like previously mentioned, the self-efficacy scale will measure both self-perception and self-efficacy. Therefore, hypothesis 2 also states that when college life satisfaction is low, so is self-efficacy. So in the graph, we can see the predicted differences in generational status. We also see when self-efficacy is low, so is college life satisfaction, as well as the opposite. So my last hypothesis states that being high in eroticism and low in openness, conscientiousness, agreeableness, and extroversion will correlate with low social connectedness. In this predicted graph, we can see the generational differences in averages, as well as a clear picture of what I think will happen when a variable is low and when it is high. So there are limitations to this study. The measures are brief due to the amount of variables that are being studied. For example, the personality questionnaire consists of 10 questions. So we cannot get a thorough examination of the personalities in each participant. Additionally, the motivation of participants may skew the data. Most students use SONA as a means as extra credit, therefore factors like self-efficacy may be affected. This study is also restricted or just on psychology students are able to participate. Therefore, this may also affect the responses to the questionnaires. Now to get into the significance of the study. There is research that disadvantaged people in our society experience imposter's feelings, specifically women and African-American people. So why is this so? I believe it has something to do with navigating spaces like the workforce or academic, etc., that weren't created for them. Imagine being in a space that wasn't originally made for you, wouldn't you feel like you didn't belong? It is also important in understanding how these feelings can impact performance. Can doubting your skills cause your work to suffer? And this research can also help to bring about more prevention strategies for the imposter phenomenon, as well as create more resources that address these cognitive self-handicapping behaviors. So thank you all for your time for listening to my presentation.
Wonderful, thank you. That was great. We have time for questions. David.
Real quick, so I know that in Dr. Eddington's lab, they've looked a little bit at imposter syndrome and goal attainment and things along those lines as well. Are you're just looking at undergraduate populations, correct?
Yes, that is correct.
So would you anticipate seeing like a sort of exaggeration of effect if that individual were to suffer from imposter syndrome at the undergraduate level, being first generation, and then also move on to graduate school where those requirements kind of become a lot more beefy and intimidating?
Yes, because most people don't go to grad school. Sometimes they don't have the resources to do that, and so I do expect that imposterism will be high in graduate students as well.
Stanasha, you alluded to this. I wasn't sure. Will you be able to measure intersectionality effects? Like, will you have enough of a sample to look at people that fall into multiple categories where we might be a little, they're maybe more vulnerable? So thinking about, minoritized groups. So not just first gen, but also being minoritized. Is that part of the plan with this study, or just looking at it overall?
The plan of the study is to look at it overall, but we are looking at like demographic factors. So like, if our regression models, I guess, would like look to see if there is a relationship between minorities and the IP and generation status in the IP, or gender or sex in the IP, then yeah. Does that answer your question?
It does, thank you.
Okay.
Other questions? Emily?
Yeah, so hi, I'm Emily Stamey. I'm over at the Weatherspoon Art Museum. So I'm going to ask for all of your grace as I form my question because I don't know my psychology terms and I might be putting cart before the horse as I ask this sort of, I guess maybe it's a methodological question. But I tuned in and was super curious to hear your talk, especially because I want to know what we can do at the Weatherspoon to help all of our first gen students. I mean, that's something I'm passionate about every day when I come to campus. Are there ways in which the questions that you're asking and the things that you're looking for, do you have ideas already in mind of things we might be doing to help? And does that inform the questions, or can that not come until after like the first body of research is done?
Like, do you mean, do I think that there are already like resources or programs implemented by UNCG that can help with these feelings?
Or things that you just think that everyone on campus could be doing that would be helpful, and your research will show us that those things could be helpful, or can we not come to those interventions until after we have more research? Sorry, I know I'm not framing this very clearly.
No, you're fine.
I want to know what I can do to help. That's the end part of the question.
Yeah, I think a lot of people feel that, especially if they're not in these shoes. Like, how can I help? How can we help these students who feel like they do not belong in these environments, not feel that way? But a lot of it has something to do with the individual person and how they view themselves in these contexts. And so I guess we'd first start with that, prevention strategies to, I guess, prevent these feelings. And then we'd look at to see how institutions can better offer programs, but UNCG does offer some programs for students. Like I know that there's a program for first gens and things like that. And then they offer a lot of programs that help students get, I guess, acclimated into these spaces, like joining more sports. We have a lot of clubs and things like that. And so there are things like that, but it's just bridging this gap between these feelings and, I guess, making them a way to join these groups.
Okay, awesome. Thank you.
You're welcome.
So Nasha, you mentioned your interest in the personality variable component, and that really goes well with Emily's point about what level of intervention. We can't really change their personalities necessarily, but could you talk a little bit about which personality characteristics you think would be sort of more adaptable, and whether there's any room to move there, right? In terms of just like I'm thinking about something like extroversion. A person may not naturally be social. They might, preserve energy and want to be by themselves. But do you think that there's an impact there of interacting with other first gen or engaging, say, in like heading over the Weatherspoon and taking like the bold leap of like, I'll walk in and find a group of people, even though I feel like it. Like, do you have some thoughts about that personality piece? I just think it's really interesting.
Yeah. Well, honestly, I feel like the personality piece is like the big piece of this study, in my opinion. So like there is studies that someone who is high in extroversion are more likely to make friends. So like, I don't want to say fake it till you make it, but sometimes you kind of have to do this. So to say, if I am able to speak to 2 people today, maybe I can make a friend or something like that. Or if I can open up myself, or like, I don't know, instead of looking like this, maybe have my arms down and maybe someone will like come up to me. And so I guess that is an aspect of openness. And so, yeah, that can help with, I guess, making friends as well.
Great. Yeah, that's so interesting. And it seems like there is room to move with that, as you're saying, where it's still your personality, but you're pushing yourself a little bit. And yeah, that could certainly inform interventions or programs. Yeah, wonderful. Other questions for Stanasha before we move on? All right, excellent. Thank you again.
Thank you, guys.
Final speaker is David Miller. David Miller is a senior and was in my honors class. I haven't seen him in a while, but so it's good to see you here. So he is in the honors program, of course. He's pursuing a Bachelor of Science. He's a Mark U. Rise Fellow, doing work that focuses very much on his own background in military training and mental health outcomes in people that have been in the military. So he's going to talk about the work that he's done in that field, and I will let him take it away.
All right. Can everybody hear me okay? Because I'm going to end up taking a step back. I talk with my hands and I don't want to hit my computer. All right. So my name is David Miller, and this presentation will be on my research and the pilot study for the Warrior Mentality Scale, which was proposed as a novel measure of the long-term effects of military training and lived experience on an individual's patterns of thinking, behaviors, emotion regulation strategies, as well as their perception and detection of threat stimuli within their environment. When we look at a comparison between veterans of our nation's armed forces and the general population at large, we notice that there are distinct disparities in rates of mental health disorders between these two populations. Most troublingly, we notice that there is significant variance around the rates of suicidality between the two. So as psychologists, the question then becomes, what sort of unique psychological factors are veterans of our nation's military being exposed to that simply may not be encountered by individuals within the general population? And when we're talking about a military population, the first thing that comes to most people's mind is the aspect of combat. Combat is highly interesting to social scientists because we understand the ways in which severely traumatic and stressful and chaotic events can impact an individual's mental health outcomes from a civilian population. With that understanding, it becomes very easy to take these accepted principles and apply them to a new population while adjusting for differences in the environment and situation. But beyond just combat, there are a slew of potential contributing and causal factors to these increases in mental health disorders and suicidality, ranging from psychological factors of increased difficulties in emotion regulation and anger among veterans, to moral injury, to neurological factors of traumatic and multiple traumatic brain injuries, even to advancements in medicine and technology that allow our service members to survive much more severe wounds than they ever would have been able to even 30 years ago. And with those increases in ability to survive with these extreme injuries comes a marked increase in potential for mental health dysfunction. But one factor that I noticed was largely absent from the current literature was the factor of military training. Because before an individual ever sets foot on foreign soil or even reaches the unit that they will actually be assigned to deploy, they will have undergone hundreds or thousands of hours of training targeted at producing specific results and outcomes in the individual within a brand new, novel, and highly unique environment of military service. And an important thing to understand about training within a military context is that these events do not occur in isolation from one another. Yes, they teach us individual and specific skills such as operating weapon systems or moving and performing in a tactical or strategic manner. But beyond that, we're also teaching our service members the effective emotion regulation strategies to navigate intensely chaotic and highly emotional and variable situations. So armed with this idea that we are very much teaching our service members more than just procedural skills when they are training, I set out to develop a scale to target if there is the presence of these unique patterns of thinking, behavior, and regulation strategies within military populations that may become maladaptive when removed from this highly specific and unique environment. And this scale is built on the principle that these behaviors and patterns of thinking are going to be reinforced through long-term repeated simulated exposure over a course of an individual's service career, whether that be 4 years on the low end or 20 to 30 years on the high end. This is also based on principles and strategies of training methodology utilized by the United States military, which targets our training towards intensely immersive and highly realistic training environments to prepare our service members as effectively as possible to face the chaos that is inherent to warfare. Now, it's important to also understand that we would not anticipate to see the same level of effect broadly across the military. As individuals get closer and closer to combat or supporting combat operations being the primary function of their job, the greater the rate of exposure and also the greater the functional utility of utilizing these specific patterns of behavior and thought become for the individual. So as I tried to conceptualize what items I could include on a scale to target these particular areas, I came out with 3 categories that are very closely interrelated, and one category seeking to measure an individual's perception of their social support, both while they are within the highly integrated and collective environment of military service, and after they have been discharged from service and lose that cohesive structure. But the rest of the scale is built on a very simple psychological principle that the way that we perceive and think about the world around us will affect our behaviors within it. And with our military individuals, as I said earlier, the closer you get to combat being your primary job, the greater utility and the greater frequency you are going to have to utilize these patterns of thought. If these behaviors also have that high level of functional utility within this environment. If I am training or deployed in a combat zone, the ability to utilize things like expression suppression to push down negative emotional states, allowing myself to maintain awareness of my surroundings and be able to effectively preempt threat, to identify it prior to an attack, gains a major functional utility and absolute necessity for the safety of the individual and the collective as a whole. For recruitment for my study, we used a wide variety of means, my favorite of which was getting to collaborate with another military veteran and scientific researcher in Tom Smoot over with weliftandshift.org. He did a great job of helping with outreach to the veteran community and really generating a lot more attention and participation from the population. Administration was done completely on Qualtrics. Individuals reached out to us and provided their contact information and interest in our study by either scanning a QR code on our flyers or social media posts or following a hyperlink. Once we received their contact, we provided them with a unique ID number, along with instructions and a link to our survey battery. Once they had completed the battery, they were compensated with a $25 electronic gift card via the email that they provided us in the contact information survey. For our pilot, we managed to recruit 31 individuals, though 2 responses did have to be removed from the data set due to negligent pattern in the response times. The average age of our participants came out to 35.5 years old, with an average age at enlistment of 19 years old and an average time in service just under 7 years. While our demographics did skew a little bit heavily towards Caucasian and male, with consideration paid to the small size and the exclusive nature of the population we're recruiting from, I was very pleased with the demographic breakdown that we were able to achieve. And I think that really reflects on the demographic diversity of the military as an overall structure. The hypotheses for this study were very simple, as it was a very small population and very preliminary pilot study. The initial hypothesis being that the warrior mentality scale would have acceptable psychometric properties and good internal consistency to justify moving farther forward with this research and development. My other hypothesis was that the scores on the warrior mentality scale would correlate with current widely accepted measures in the field of psychology, which seek to target the presence of similar constructs. Those measures being the difficulties of emotion regulation scale, which is a widely used, repeatedly validated gold standard measure within the field of psychology that is proven to have very good predictive ability towards problems of emotion regulation like depression and anxiety. This is where we were hoping to see our best correlation because this scale is so widely used and has such good predictive capability. If our scale is measuring similar constructs, then we would anticipate that scores would be similar. We also utilize the Carver Cope inventory, which is an absolutely massive scale with 15 subscales and 60 items, but it is designed to be used in a very piecemeal fashion, so you can pick which subscales you want that target specific methods of coping with negative life events and negative emotional states. The last measures that we utilized were the RAND Social Support Survey, which is a fairly widely used measure that seeks to target every levels of everyday social support across a wide variety of situations and contexts. The last measure that we utilized was the Dimensions of Anger Reaction Scale, which was initially developed to measure for the presence of anger in post-traumatic stress disorder in veterans, but in recent years has proven to have very good utility at predicting trait anger in a much more general population. This is the other scale that we were hoping to have very good very good consistency with, because anger has gained a lot of attention, especially in depression and anxiety research of late, due to its high level of correlation with much poorer outcomes, such as self-harm ideation or suicidal ideation. The results of the study did validate our initial hypothesis, and we received excellent internal consistency for the warrior mentality scale in this form, though with the very small population. This is to be taken with a grain of salt, but is very encouraging. While we did not see correlations with every measure that we hoped we would, we did have correlation with the two that we hoped to have correlation with the most, that being the difficulties of emotion regulation scale and the dimensions of anger reaction scale. This really helps to narrow down our focus on what this scale does well and where we can kind of cut weight to more effectively target these constructs in future studies. Our second wave is currently in progress, in which we will be recruiting a much larger population to see if we maintain the same levels of internal consistency and correlation with currently accepted measures. We will also be recruiting a non-veteran population to compare scores to establish if the warrior mentality scale is indeed a veteran-specific measure, or if there might be an underlying factor that would allow for some more generalization to a regular population. We did remove largely the social support mechanisms, as we received no correlation and no factors of note in that area, and targeted this more adapted form of the scale more effectively towards emotion regulation, emotional flexibility, anxiety, and stress. To do this, we will be seeking for correlations with the anxiety and stress subscales of the DAS-21. We will be leaving out depression since the DERS already does that pretty well in the interest of keeping our battery brief. We've also added in the acceptance and action questionnaire, which is a measure of emotional flexibility or an individual's ability to move between emotion regulation strategies fluidly as the situation dictates, rather than utilizing one emotion regulation strategy as a blanket for all situations. Last but not least, every single person on this slide has been absolutely critical to my research reaching this point. Doctors Eddington, Wisco, and Estel have been amazing and always willing to sit and listen to an excited undergraduate ramble about their crazy ideas. Miss Tracy has been amazing as a cohort mom for us over in the MARC program, so she needs a shout out. And last but not least, the UNCG MARC program is what made this research possible. Veterans are a difficult population to recruit from, and it's a very small and selective population. So being able to have that funding to provide compensation made every bit of this possible. And that is all I have.
Terrific. Thank you very much. That was excellent. We will take questions. Questions for David? Stanasha, I see your hand is up.
Yes. So David, interesting. I love your topic. It's very relevant. So I have a question. So do you predict wave 2's results to be similar to the first study? Because I'm only asking this because in the first one, your demographic was mostly white males, am I right? And so like, what do you think this this race like will have on the results? I don't know.
So currently I've actually completed data collection for my veteran population. I haven't gotten to get as deep into factor analysis and everything yet, but largely, yes, the responses have remained consistent. We actually got a better Cron box from the second wave than we did in the initial. It came out to about 0.91 as opposed to So great looking forward. And we got moderate to good correlations with every single measure that we used for comparison. So it seems that abandoning the social aspects was really what was holding it back. And it does seem to do well at targeting these constructs that I'm proposing.
Thank you. I can really tell that you're very passionate about this topic too.
Thank you. I really enjoy it.
David, I'm wondering what you would say from an interventional perspective. I mean, I'm just so struck by, I mean, you know, you talk about the average age of entry, they're 19. I mean, oh my goodness, right? Developmentally, if we think about stages and we think about like emerging adulthood and just this task of doing something so serious and the way that you have to be so flexible with your emotions. I mean, what is the healthy thing to do to prepare people both before and after? I mean, what are your thoughts there in terms of like, what action can be taken to kind of optimize well-being later? Because of course we all hear about those effects afterward. You know, what's the pre and post looking like? And I know obviously you can't answer that from one study, but just in terms of this measurement, and what you would quote prescribe for the moment. Can you talk a little bit about that?
Absolutely. So ideally, the form that this will take in the long term is having this scale as a method to be able to easily administer to service members on their way out of service. Because if we can identify things that do have good predictive capability towards these problems of emotion regulation and mental health, then we can get that early intervention, which is a big part of the problem when an individual leaves DoD healthcare to transition to an entirely different side of the government for the VA. Also, what I'm hoping to be able to test in ideally grad school or something where I can run treatment designs is to focus less on attempting to push these patterns of thought and behavior towards extinction, so much as finding ways to take these very long-term conditioned behaviors and adapt them into more effective forms. I've heard several veterans talk to me anecdotally about getting into arguments with their therapists and saying, no, these are things that I was trained to do. This isn't just my trauma. This is what I need to do. And therapists telling them, you don't know what you're talking about. This is your trauma. Because that's the way we conceptualize it as psychologists. It's very difficult to understand the effects of these training environments and the styles of training we engage in if you don't know what they are. And what I've come to realize is that we have not always trained the way that we do now. In the 1950s, we shifted towards this much more intensive, realistic, and immersive training, which interestingly enough, draws a very neat correlation with rises in mental health disorders and suicidality through the wars in Vietnam, Iraq, and Afghanistan subsequently, whereas we did not see those same impacts in World Wars I, II, or Korea. So that is what initially led me down this road. And I think just being able to get in early and find adaptive mechanisms to help people change these behaviors rather than trying to push them all the way to extinction has better likely outcomes.
Yeah, I think it's fascinating that you point to this disconnect between the training side of things and then what therapists know about this and how can they help if they don't understand that element. So it seems like that's the key piece of let's connect here and figure out like, okay, what were they taught? How is this view adaptive? And now what do we do? And I think, yeah, this idea that you could just extinguish things just isn't realistic given that background in history. So just really absolutely fascinating. Anyone else have any questions for David? Jasmine.
Yeah, thank you so much for your presentation. I thought this was so fascinating, and I'm so impressed with your amazing alphas and your scales. This is just incredible. And I was curious, in this larger second wave of data collection that you have, if you have any opportunities to look at kind of more specific differences in people's combat experiences. And I'm thinking specifically about potential differences between people who like went into combat and then are home and are done versus people who go in and come back out and go in and come back out. Because I think, especially with what you were just saying about what is the, like moving away from extinction for people who are kind of going in and out of combat, that might be especially challenging, right? If they're, using their training and then coming home and then using their training again. Like, what kind of information do you have in wave 2?
Absolutely. So I haven't gone specifically into looking at combat exposure since it's just been kind of preliminary, but the way that I've conceptualized this idea based on these stimulus pre-exposures that we get through training in preparation for combat, I think that it may be fundamentally altering what we understand about conditioning in post-traumatic stress disorder from combat. And the example I use is very brief. I'll try not to eat up too much time here. But for instance, an individual needs to go down the street to a gas station to grab something at night. They grab their keys and phone, almost get there. Somebody jumps out, beats them down, grabs their stuff, runs off into the night. In that situation, this individual has this perception of safety in their everyday life. And when this traumatic event occurs, that expectation of safety is grossly violated, which allows for the etiology of post-traumatic stress disorder and these maladaptive safety behaviors to find a place. Within combat, we don't necessarily have that because you have this learned assumption of danger. So now when the traumatic event occurs, rather than beginning these behaviors, it is deeply reinforcing the utility of those behaviors. So I think that it could be much more deeply reinforcing. So the more that you're exposed to it, the higher the level of utility, the higher the reinforcement, and the more deeply ingrained those behaviors would become.
Any other questions for David? We are just about out of time here, but we have time if there's anything else. I don't see anyone. Last call. All right, well, congratulations to all of you. This is really, truly excellent work that you've contributed. You're really producing novel findings here that are extremely important, extremely exciting, and congratulations. And especially during such a difficult time doing this work during the pandemic, even more so challenging. So I applaud all of you. Thank you for sharing your research today, and thank you to everyone for attending. Have a wonderful rest of the day, everyone.